This module was, the last update was in 2016, and we all just following this module until 10 days or 15 days back. There is a new guideline also from the Green Top guideline was released and talking about the updates of this topic. And unfortunately, there is big difference between the recent one and the old one, starting from the definition of the hyperemesis gravidarum. So it's recommended just to follow the recent one, and before practicing and before doing the guidelines or taking the materials from your study partner or your friend, you should check that you are following the recent guideline. So today we are going to talk about the newer guideline of the hyperemesis, the nausea and vomiting with pregnancy and hyperemesis that was released in day 6 February. Sorry, not 2014, it's 2024. Sorry for this one. After that, we will have another topic, which is the gestational trophoblastic disease and management and follow-up. So firstly, we will start with the nausea and vomiting and hyperemesis with the pregnancy. First of all, we should know that nausea and vomiting with pregnancy, it's affecting 90% of the pregnant women. Previously, in the old guideline, it was 80% only. And there is a questions in books. The answer you will find it's 80%, but now it's 90%. So please concentrate with, because this is a single best answer, and you should know the recent update. The second thing, you should know that the typical stay in the hospital, it's took around 3 to 4 days or more. The thing that it's different from the previous one, which is the diagnostic criteria of the hyperemesis. Firstly, the diagnostic criteria of nausea vomiting with pregnancy, which is having a symptoms of nausea and or vomiting during the pregnancy when the onset is prior to 16 weeks of gestation and where there is no other causes. So we have two things. Firstly, nausea and vomiting with pregnancy less than 16 weeks and excluding all the other causes. This is the diagnostic criteria of nausea and vomiting with pregnancy. Diagnostic criteria for the hyperemesis gravidarum, and please concentrate well here. Please concentrate. It's a severe form of nausea and vomiting with pregnancy, which is affect 0.3 to 3.6%, and interfering with the quality of life and the ability to eat and drink normally, and strongly limit the daily activity of life. These are the definition and the diagnostic criteria of the hyperemesis gravidarum. Signs of dehydration are contributory to diagnosis, not necessary to the diagnosis. Previously, there was a triad. I put an X mark about the triad because it's not recommended now to diagnose the hyperemesis gravidarum. This triad was having 3 points to diagnose the hyperemesis gravidarum, which is having more than 5% of weight loss and signs of dehydration and electrolyte imbalance. Previously, in 2016 guideline, it's necessary to have all the 3 points of the triad to diagnose the hyperemesis gravidarum. But now, it's not necessary. Now, you will diagnose the hyperemesis gravidarum by severe form of nausea and vomiting with pregnancy that interfering with the quality of life and the ability to eat and drink and limits your daily activity. This is enough to diagnose the hyperemesis gravidarum. Second thing, we know from the previous guideline that we have a score for quantification of the severity of hyperemesis gravidarum and nausea and vomiting, which is the pregnancy unique quantification of emesis, BUQE scoring. But now in the recent guideline, we have an extra tool for the hyperemesis, which is the hyperemesis level protection tool, help tool. So as per the recent recommendation, we have two tools to assess the severity and the treatment response for the hyperemesis gravidarum, which is the BUQE tool and help tool. And I will tell you in the next slide the difference between the two tools and when to use this one and when to use the other one. Clinicians should be aware of the features in the history and the examination and investigations. This will allow nausea and vomiting with pregnancy and hyperemesis to be assessed and for their severity to be monitored. We will talk about the points in the history and the examination and investigation, but you should know all of them before start managing this condition. Look here, this is another cross point. This means that it's not necessary in the recent guideline. Previously, ketonuria, it was an indicator for dehydration and also the decision and the treatment of decision and site of the treatment depend on the ketonuria. But in the recent guideline, they say clearly that the ketonuria, it's not an indicator for dehydration in pregnancy, and you should not use to assess the severity. So it's not an indicator, and even it's not used to assess the severity of the condition. Okay? As I told you, onset of nausea or vomiting in the first trimester. So if there is initial onset of nausea and vomiting with pregnancy more than 16 weeks, you should investigate for other causes of vomiting, because mostly it will not be the nausea or vomiting of pregnancy or hyperemesis gravidarum. Mostly there is a hidden medical or surgical condition. Nausea and vomiting with pregnancy typically start between 4 to 7 weeks, and her peak is around 9th week, and resolve it around 16 weeks. So remember these numbers because it's important for single best answer. And there is a question in some old book about the peak of nausea and vomiting with pregnancy, because this information also are the same in the previous and old guideline. So start at 7, peak at 9, drop at 16. Remember these words. Start at 7, peak at 9, drop at 16. So for some points in the diagnostic criteria of nausea and vomiting with hyperemesis, nausea and vomiting with pregnancy and hyperemesis are associated with hyponatremia, hypokalemia, low serum urea, raised hematocrit, ketonuria, metabolic hypochloremic acidosis, and metabolic acidosis may be developed. So remember this point that nausea and vomiting with pregnancy and hyperemesis are hypo in everything except the hematocrit are raised, because decrease the amount of blood volume due to decrease the fluids in the body. So hyponatremia, hypokalemia, low serum urea, hypochloremia, ketonuria, and raised hemoglobin. The second thing which is important also for questions in the exam, which is the percentages. Nausea and vomiting with pregnancy and hyperemesis having a risk of 2/3 of the women with hyperemesis have an abnormality in the thyroid function test, and 40% of the women with hyperemesis gravidarum having an abnormality in the liver function test. So it's important for single best answer. 2/3 and So it's important for this topic to know that 2/3 of the cases having abnormality in the thyroid function test and 40% having abnormality in the liver function test. But please concentrate well here. Even if you find abnormality in the thyroid function test, this is not meaning that there is a derangement in the thyroid function, right? Because 2/3 are linked to the abnormal thyroid function test, but there is no antibodies for the thyroid are there, and this patient is athyroid clinically. So rarely in patient with hyperemesis gravidarum to have a thyroid antibodies or derangement of the thyroid function clinically or symptoms of thyrotoxicosis. And the second thing that will tell you that there is no abnormality in the thyroid function, which is the condition of thyrotoxicosis will be resolved as the hyperemesis gravidarum are improved. So please concentrate well about this point, because also it's an exam question as a single best answer. 2/3 of the patients with hyperemesis gravidarum having an abnormality in the thyroid function test. But there is no raise in the thyroid antibodies, and the condition are resolved and the abnormality of the thyroid function test resolved when the hyperemesis gravidarum are improved. And there is for sure no need for treatment by antithyroid drug for this condition. The second thing, which is the liver function test. Liver function test also is deranged in 40% of the cases, and also bilirubin and amylase may be mildly elevated, and all these abnormality will be improved as the hyperemesis gravidarum are resolved. Let's talk about the scoring and the difference between BUQE and HELP scoring. BUQE scoring is validated to score the severity of nausea and vomiting with pregnancy and the treatment response for mild to moderate nausea and vomiting. And it's not for the treatment response for severe form of nausea and vomiting with pregnancy. So this means that what are the score of treatment response for the severe form? Yes, it's the HELP score. So HELP score is validated for determining the treatment response in severe form of nausea and vomiting with pregnancy and hyperemesis. So please concentrate for the difference here, because this is a new information and maybe an exam question as well. BUQE scoring, it's done to assess the severity. HELP scoring, it's done to assess the treatment response only. BUQE scoring assess the severity and the treatment response, but treatment response for mild to moderate only. HELP scoring not assessing the severity, it assessing the treatment response in the severe form of nausea and vomiting and hyperemesis. Okay, now it's clear? Clear for repeat? Okay, I will repeat it again. So we have two scoring, BUQE scoring and HELP scoring. BUQE scoring is validated to assess the severity or the treatment response, but treatment response for mild to moderate only. HELP scoring, it's not assessed and validated to assess the severity. It's assessed to determine the treatment response in both, in severe form of nausea and vomiting with hyperemesis. Dr. Haytham, thank you for your questions. No, we will not use them together. They are complementary. We will start with the BUQE scoring to assess the severity of the nausea and vomiting with pregnancy. This is from the start. And after that, when we start treating the condition, if the condition is mild to severe, so we will continue on BUQE scoring. But if the condition is severe form of nausea and vomiting require inpatient admission, so we will use HELP scoring to validate the score and determine the treatment response for the severe form. This is the pregnancy unit quantification of emesis, and we have cut off mild is 6, moderate 7 to 12, severe 13 to 15. How we do the scoring? We do the scoring by asking these questions, and every answer will have a score. For example, in the last 24 hours, have you vomited or thrown up? If she told you no, you will take a score 1. If she told you that 1 to 2 times, score 2. 7 or more, this means that score 5. Okay? So you will collect all the scores and you will have a number to determine either it's a mild or moderate or severe. This is for the pregnancy unit quantification of emesis. The second score, which is the HELP score. HELP score also having a marks, a numbers. Mild, it will be less than 19. Moderate, it's from 20 to 32. Severe, from 33 to 60 score. And if you find here, you will find all the questions that it's required to ask the patient, and here the numbers in the score. If you look here to all the questions, you will find that there is a questions about the drugs, number of drugs used for nausea and vomiting. This means this is a scoring for treatment response, not a scoring to assess severity only of condition. There is another questions about the treatment, like may anti-nausea and vomiting medication stay down or thrown up. This means that it's scoring for the treating of the condition, not a scoring to assessing the severity from the start. So like what Dr. Haitham asked, firstly, we will start with the BUQE to assess severity of condition to determine either that this condition will be treated here in the community or in the ambulatory daycare or inpatient. And after that, we will start the treatment. If we are starting treatment for severe form, directly we will go for HELP. If we are doing a treatment for mild to severe and we need to assess the treatment response, we will go directly for the BUQ scoring. These are the points that needed to be known in the history. Firstly, we need to know about any previous history of nausea and vomiting with pregnancy, quantification the severity by using BUQ or HELP, as we mentioned, asking about any self-reported nutritional status or rapid weight loss or something like this, and ask about all comorbidities because it will be complicated if the patients have any comorbidities and require from them to take medication and she cannot take medications. Like the patient of the epilepsy, it's required to take anti-epileptic drug. So if she cannot take the anti-epileptic drug, the patient will have seizure. So it's a complicated thing. So that's why we ask about this in the history as well. We need to ask about relevant surgical history, like gastric bypass, like band, like sleeve gastrectomy, or all these points that may also interfere with the patient and the digestive mechanism, or make her to throw up the medication that given by tablets. Also, we need to exclude other causes like abdominal pain, like infections, like any drug history, like H. pylori infection, all these points. These are points in the history. For the examination, for sure, we need to examine the patient for blood pressure, pulse, temperature, oxygen saturation, respiratory rate, and any signs of dehydrations like sunken eyes, dry lips, oliguria, tachycardia, and signs of malnutrition like weight loss for more than 5%, like muscle wasting, like neurological signs all these points. Neurological signs like confusion, like nystagmus, like ataxia, like vernix encephalopathy, all these points. So now I have one question, and please, I need from all of you to answer this question in the chat bar. Okay? If the patient that have an hyperemesis gravidarum got convulsions or seizures, so what are the causes? Oh, sorry, what are the cause, not the causes, for these convulsions? I mean hyperemesis gravidarum related causes, not a patient having epilepsy or something like this. Do you have an answer? What type of electrolyte imbalance, Dr. Anam? Abnormal liver.
Hyponatremia.
Yes, exactly, Dr. Iman, Dr. Haitham, Dr. Ibtisam. Very clever. Okay, so it's the hyponatremia, yes, because some of the candidates are confused about this reason and the vernix encephalopathy. Vernix encephalopathy will not cause seizure for the patient. Okay, so the reason for this is the hyponatremia. If you would like to know why the reason is the hyponatremia, because hyponatremia will make we will make some kind of problem. We call it a pontine myelinosis. This is shifting of the fluids will be more to the brain and cause this problem. And also this problem will be more aggravated if you did aggressive fluid replacement for this patient. And we will talk about fluid replacement in the management plan. Just 1 second, please. So these are the investigations that it's needed to be done for this patient. We need to check about the electrolyte imbalance, hypokalemia, hyponatremia, chronic kidney disease, high creat level or high urea, or all these points. We need to do full blood count to check about infection, anemia, raised hemoglobin, or hematocrit, as we mentioned. We need to do urine analysis to check if there is infection and high nitrates. We need to do middle stream urine culture as well. Do you hear me clearly or there is an echo in the voice? Please answer.
Clear.
Okay, thank you. After that, which is very important thing in patient with hyperemesis gravidarum, which is to exclude multiple pregnancy and trophoblastic disease, because these 2 points will make the patient to have hyperemesis symptoms also as well. In case, and please concentrate for the rule here, we will not do thyroid function test and liver function test for all the cases. We will do this only for refractory cases or there is a history of previous admission before. At that time, we will do thyroid function test and liver function test to exclude all the liver diseases as hepatitis, gallstone, and malnutrition. Also, we will do calcium and phosphate and amylase to exclude the pancreatitis, and VPG may be required. And as I told you, there is no antibodies for thyroid in nausea and vomiting with pregnancy and hyperemesis. Now, let's start with the plan of care in this patient. Plan of care in this patient. Sorry for interruption. Please mute your mics. Mute your mics all, please. So sorry, I will mute all. Just keep your questions in the chat bar if you have any question. After finishing this module, you can open your mic and ask any question you would like. Am I audible now? Just please confirm this on the chat bar, please. Okay, thank you. So, care of this patient would be either in the community with antiemetics or in the ambulatory daycare or inpatient. We will start the patient with caring in the community for the mild form of nausea and vomiting by only oral or intramuscular antiemetics. And how we know that the patient is mild form? By using the BUQ-E scoring. If we find it's a mild form, so directly the care will be in the community. Caring the patient in the ambulatory daycare, it will be if this patient having measurements that was done in the community and failed, or the primary care and failed. I mean, if I start the caring in the community for the mild form and it's not improved, so directly we will shift the patient for the ambulatory daycare. Ambulatory daycare, it's mean that a place that she will take care for 24 hours and then she can go home. She will not be being admitted in the hospital. So the inpatient care, when we decide to do inpatient care for this patient, it's not depending on the ketonuria or something like this, like in the previous topic. It's depending on, we should consider if there is at least one of the following: continued nausea and vomiting associated with clinical dehydration, like weight loss more than 5 of the body weight, despite of having an oral antiemetics. This is the first thing. The second indication, suspected or confirmed comorbidities, such as urinary tract infections, such as inability to tolerate oral antibiotics. When we just suspecting or confirmed other comorbidities, directly we will admit the patient. The third thing, if the patient have a coexistent comorbidity like epilepsy, like diabetes, like HIV, like a psychiatric problem, like as we mentioned epilepsy, because these symptoms, and because that there is this patient will be unable to tolerate taking the oral medications for her condition, so it's required to admit this patient in the hospital if she have comorbidities. So the extra points than the old guideline, which is having a comorbidities such epilepsy, diabetes, HIV, or confirmed or suspected comorbidity as an UTI or an ability to tolerate oral antibodies. Where inpatient care is required, as I told you, we should do an ultrasound to confirm the viability of gestational age and to assess the multiple pregnancy and trophoblastic disease. Unless there are other medical reasons for an urgent ultrasound scan, this can be scheduled in the next available appointment. So concentrate well, please. Because there is a single best answer about this point. We do an ultrasound as a regular or routine in the next appointment to confirm the viability, to assess the multiple pregnancy and trophoblastic disease. But if we have any medical reason for urgent ultrasound scan, we should do it urgent, not a routine in the next appointment. Let's talk now about some implications. The women that have a recurrent or ongoing nausea and vomiting and hyperemesis, despite of adequate ambulatory daycare treatment, they should be cared as an inpatient because there is associated with some complications like electrolyte imbalance and nutritional deficiency. So that's why if she have recurrent or ongoing nausea and vomiting, please admit the patient to save her from these complications. Trophoblastic disease and multiple pregnancy are associated with an increased risk of hyperemesis gravidarum, but will not affect the initial care. So we will do this only to diagnose and to know that these two things, trophoblastic disease and multiple pregnancy, are increasing the risk of hyperemesis gravidarum. Thiamine store, which is the vitamin B1, in previous healthy individual can be depleted rapidly and cause symptoms of tachycardia and weakness and decrease the deep tendon reflexes within 1 week without intake. So that's why we recommend to give thiamine store in the patient having nausea and vomiting and hyperemesis, because depletion of this vitamin will lead to have these symptoms: tachycardia, weakness, and decrease deep tendon reflexes within 1 week. And now we will talk about the line of the management. And I'm so sorry to tell you that because this is an update guideline, so there is some differences from the old guideline, especially in the care and the type of medications. So we will talk about this and touch all these differences now. First of all, we all used to answer the question of what are the first medication to be used as antihypertensive. The answer would be cyclizine, right? But now it's different. The RCOG and the Green Top guideline, the recent one, recommend doxylamine and pyridoxine together to be given as the first line. And the generic name is Zonvia, as I wrote here in this box. And this medication, it's the only one licensed by the RCOG to be given as the first line of the management of the patient with hyperemesis gravidarum. So remember these two names, doxylamine together with pyridoxine, which is the vitamin B6, to be given, and we can titrate the dose and increase the dose until 20 to 20 milligram for each. Generic name is Zonvia. But we can also use as a second option cyclizine if the first one is not available, or prochlorperazine, or promethazine, or chloropromazine. We can use all of these options as the first line, but please remember this start point as the first option. No need to memorize the doses of the medication, just remember the name only. If the first line not helping the patient, you can go for the second line. The second line, which is the metoclopramide, or domperidone, or ondansetron. Also, again, no need to remember the numbers, just the name. Metoclopramide having a problem of the extrapyramidal manifestation, and we will talk about this in the next slide. But just remember that from the old guideline and also the recent one, they recommend use the metoclopramide only a maximum for 5 days, not more. This is specifically for the metoclopramide. Domperidone can be given at any time. Ondansetron also can be given. But we have one thing also, special two things about the ondansetron we will discuss in the next slide, inshallah. The third line, which is the hydrocortisone. So the first one, which is the doxylamine, pyridoxine, and all antihistaminics. The second line, which is the metoclopramide, domperidone, or ondansetron. The third line, which is the steroid. If all these lines are failed, we can give the hydrocortisone. Hydrocortisone can be given 100 milligram twice daily until clinical improvement. Once there is a clinical improvement, we will convert it to prednisolone, 40 to 50 milligrams daily. Then we will taper the dose gradually until the lowest maintenance dose that control the symptoms of the patient. So start with 100 milligrams, convert to prednisolone after improvement, tapering the dose until the lowest maintenance dose. For the corticosteroid, we should not use it as a first line or second line. We should use only if all the other standard therapies have been failed. And if the patient is using corticosteroid, please concentrate that it's required to measure the blood pressure monitoring and screening for diabetes at 24 to 28 weeks of gestation if she's continued on the steroid. Steroid can be used if IV fluid replacement and the antiemetics are not effective. So if I use oral antiemetics, then fluids IV, including IV antiemetics, and it's not improving, directly we will go for the steroid. Concentrate again here, it's not advised to use home ginger as it's delay the access of effective treatment. Previously, it was advised the patient to use ginger in the previous guideline, but they say clearly, if the patient called you and told you, I have this symptoms of the hyperemesis gravidarum or nausea and vomiting, Do not offer the patient to use home ginger because this will delay the access to the effective treatment until the condition will be a severe form. So forget about the ginger, but remember the vitamin B6. I think it's different than the previous guideline, but it's important to mention all these points. Combination, if no response to single treatment. So if you used one treatment and there is no improvement, you can do combination of the treatment. And it's better to do combination between first and the second lines of the treatment. This will make a synergistic effect for the treatment. In severe persistent hyperemesis gravidarum, you can use either IV form or transdermal form or rectal route form. So to conclude this slide, we need to revise these points. The first option in the first line of the management is the combination of doxylamine and pyridoxine, vitamin B6, which is the Zombia. And it's a licensed medication to be answered. So this is an exam question. Sometime the exam will ask you what are the first line of the management in the hyperemesis. You will answer doxylamine and pyridoxine. Sometime he will ask you what are the vitamins that will help you in the hyperemesis. You will answer the pyridoxine, which is the vitamin B6. Sometime the question will be what's the only licensed medication to be used for hyperemesis gravidarum as per the Green Top guideline. You will answer the Zombia, which is the doxylamine and pyridoxine. Here is the questions and how to mark about the important points in the guideline. This is the first thing. The second thing, remember that the metoclopramide is used only for 5 days. Remember the rule of corticosteroid. You will use it only if oral or IV fluid replacement with antiemetics is not effective. Do not offer ginger for the patient. Combination of medication, especially with the first and the second one, and change the route of medication in severe form, either IV or transdermal or rectal route. There is some risks of the drugs that we mentioned in the previous slide, as we mentioned about the metoclopramide, because there is a risk of extrapyramidal manifestations with the metoclopramide, so you should use as a second line of therapy. This is the first rule, and the second rule, you should administer by slow bolus injection over at least 3 minutes to help minimizing this risk. So there is no single shot of bolus injection, just give it slowly over 3 minutes. So we have two rules about the extrapyramidal manifestation. The first rule, which is not to use it more than 5 days. This is from the old guideline. And the second rule, which is to administer by a slow bolus injection for at least 3 minutes. Women should be asked about previous adverse reaction to antiemetic therapy. If there is an adverse reaction, there should prompt cessation of the medication. I mean that before giving the metoclopramide or phenothiazide, we should ask the patient about if she had any adverse reaction from this medication before. If yes, okay, so please do not use this medication. Drug-induced extrapyramidal manifestation or oculogylic crisis, which is, as I mentioned, metoclopramide and phenothiazide. Using of ondansetron having a very small and absolute risk of cardiac defects and orofacial cleft. So please, whenever you will offer an ondansetron, you should mention to the patient that there is a very tiny, small absolute risk of increasing the cardiac defects and orofacial cleft as per the recent guideline. Metoclopramide has confirmed the risk of short-term extrapyramidal disorders and tardive dyskinesia. So, in order to prescribe it for a short-term use, we should use as a maximum dose of 30 milligrams in 24 hours or 0.5 milligram per kg body weight in 24 hours. Maximum duration is 5 days. This is the most important point also in the recent guideline. It's the maximum duration, 5 days. Another new information written clearly in the new guideline: using of corticosteroid in the first trimester, it's not associated with increasing risk of congenital malformation, and also it's not an increasing risk of orofacial clefts or cardiac defects or hypospadias, because previously we used to tell the patient that using the corticosteroid in the first trimester having some clefts, oral or orofacial clefts, but they written clearly in the new guideline that there is no any increased risk of congenital malformation. So please, to memorize these things now, in as per the recent green top guideline, using of the corticosteroid in the first trimester will not have any risk for the patient, but using of the ondansetron in the first trimester, it carry some tiny small risk of cardiac defects and orofacial clefts. Urea and serum electrolyte level should be checked daily in the woman that using intravenous fluid. And I told you why, because some of these risks that that using of aggressive fluid replacement will lead to pontine myelinosis in the brain and will lead the patient to have seizures. So we need to use the urea and electrolyte levels daily in the patient that it's have been admitted in the hospital. Recurrent intractable vomiting may lead to gastroesophageal reflux disease and esophagitis and gastritis. And we have treatment for these symptoms for this problem if happen in the next slide. But remember that intractable vomiting can lead to GERD and esophagitis. Nausea and vomiting with pregnancy and hyperemesis can lead to vernix encephalopathy, and we need to give the patient vitamin B1 thiamine. The symptoms for the patient and signs for having a vernix encephalopathy, it's present with blurring of vision, unsteadiness, confusion, memory problem, drowsiness, and also if you examine the patient that you will have nystagmus, ophthalmoplegia, hyporeflexia or areflexia, or gait and or finger nose ataxia. So if you look here, you will find that the vernix encephalopathy only have hyperflexia and or areflexia, not a seizure. Seizure is by hyponatremia. And for sure, if you would like to save the patient from the vernix encephalopathy, please give vitamin B1 either alone or in a complex with complex vitamin B. Patient have a previous history of gastric reduction surgery as sleeve gastrectomy or gastric bypass, or all these surgeries may have malabsorption of oral medications, and there is an increased risk of nutrient and vitamin B and vitamin deficiency, particularly the thiamine and vitamin K. So these patients, we need to give him thiamine in order to save the patient from having the vernix encephalopathy. Oesophageal or gastroduodenoscopy is safe in pregnancy, and we need this endoscopy in case of that we have hematemesis or severe epigastric pain, and treating these points by a trial of proton pump inhibitor. This is appropriate for treatment and prevention, and proton pump inhibitor are safe in the pregnancy. So we will not interfere by the gastroduodenoscopy or oesophageoscopy only if there is a hematemesis or severe epigastric pain, and we can treat by a trial of proton pump inhibitor as it's a safe medication in the pregnancy. Some other medications that need to be used in the pregnancy: histamine B2 receptor blockers or proton pump inhibitor. They are treating the gastroesophageal reflux and the esophagitis and gastritis. I mentioned them before, which is there are some risks that occur from intractable vomiting. Thiamine supplementation, either oral 100 milligrams 3 times per day or IV as a part of vitamin B complex. Vitamin B complex is called Paprinix. This is a licensed medication to be given also as per the Green Top guideline. So we have two medications we need to memorize: Zomvia by Redoxim and Paprinix, which is the thiamine. They should be given to allow the woman admitted with vomiting or severely reduced dietary intake, especially before administration of dextrose or parenteral nutrition, because giving administration the patient dextrose or glucose while she is hyperemesis gravidarum, it will aggravate the symptoms of vernix encephalopathy. So we need to give the thiamine either alone or with the vitamin B complex injection called Paprinix. Women admitted with the hyperemesis gravidarum should be offered thromboprophylaxis with low molecular weight heparin. This will continue while she was admitted for more than 2 days, and you will stop the thromboprophylaxis once discharge. Okay, so in hyperemesis gravidarum, as per the VTE scoring of the RCOG, it's a transient score, and it's written in the score sheet, it's a score 3. Score 3, it means that it's required to be given while she was admitted for more than 2 days. After complete treating the condition and send the patient to the community, directly we will stop the thromboprophylaxis and we'll continue on the small measures of VTE prophylaxis like fluid replacement and movement and all these points. In the first 2 days admission, you can depend on graduated compressive stocking, or you can depend on the graduated compressive stocking from the start if there is a contraindication to low molecular weight heparin. So to conclude these points, once we admit the patient, and we plan to admit the patient for more than 2 days, we will directly start with thromboprophylaxis. Thromboprophylaxis continue till discharge. When you discharge a patient, you will stop the low molecular weight heparin. If there is any contraindication to low molecular weight heparin, you will just put the patient on the graduated compressive stocking. But please concentrate well, because this point is confusing. We have two transient risks for the VTE and requiring thromboprophylaxis during the pregnancy. They are the hyperemesis gravidarum and the OHSS, which is the ovarian hyperstimulation syndrome. What are the difference between both of them? The difference is, once the patient is discharged, you will stop the thromboprophylaxis in patient of hyperemesis gravidarum. But if the patient is ovarian hyperstimulation syndrome and is a severe form of ovarian hyperstimulation syndrome, you will use the thromboprophylaxis during the admission, and you will continue on the thromboprophylaxis till the end of the first trimester. So it's critical and very important point, and it's an exam question also. Start with admission for the hyperemesis. Start with admission, stop with discharge. For the OHSS, start with admission and continue till the end of the first trimester if severe or critical form. Another important point, we should inform the patient that oral iron can cause nausea and vomiting with constipation, and it's required. We can consider avoid using the iron containing preparation as it exacerbates the symptom. We can consider also alternative route of administration of the iron instead of using the oral form. So in patient having nausea and vomiting or hyperemesis gravidarum, please either stop the oral iron or shift it to alternative route because it's aggravating the symptoms. Also, women with nausea and vomiting with hyperemesis can suffer from constipation because of reduced the fluids or the food, and also because of treating the patient with ondansetron. So it's written, if you look here, you will find that they say that if the patient using ondansetron, woman should require laxative if constipation develop, because ondansetron may cause constipation as well. So we have two important points about the ondansetron. We should inform the patient using ondansetron that there is very small risk of cardiac defects and orofacial clefts, and we should inform this patient also that there is a risk of having constipation, require taking a laxative as well. Treating of gastroesophageal reflux along with the antiemetic therapy have been associated with reduced BUQE scoring and improve the quality of life score. So it's wise thing to treat the gastroesophageal reflux or gastroenteritis with proton pump inhibitor medications along with the antiemetic medications. This will help in reducing the scoring of severity of the condition. Now, let's have a look about the charts in this guideline. The first chart in which we will talk about the care in the community. For managing of the condition of hyperemesis or nausea and vomiting with pregnancy, we depend firstly on the BUQE scoring, as I mentioned, to assess the severity. If the score is less than 12, so we can manage in the community. If the score is more than 30 or equal to 13, so directly we need to shift the patient to ambulatory daycare management. But if we have one of these red flags, automatically we need to treat the patient inpatient. We need to admit the patient. What are the red flags? If there is any BUQA scoring with complication, if the patient have any complication happen with the BUEQ scoring, or if there is inability to tolerate oral intake, or there is unresponsive to outpatient management, she's taking community medications or ambulatory daycare medication but without improvement, if there is clinical dehydration, or if there is weight loss more than 5% of the body weight, or if there is confirmed or suspected any comorbidities like diabetes mellitus, like UTI, like epilepsy, like HIV, like psychiatric disorder that requires to have a medications also, and the patient will not be able to take the medication because of the nausea and the vomiting. Or if there is any concerns regarding the mental health. All these red flags required inpatient management. If we don't have all these red flags and we have score less than 13, so we will manage in the community. How we will manage in the community? We will start with the antiemetic, the first option, which is dysomphia, and we will give the patient support and reassure, and start with the oral hydration as well, and give her an advice about the oral diet, give her laxative if required, prescribe proton pump inhibitor or H2 blocker if the woman develop, as we mentioned, GERD or gastritis. This will help in reducing the score, as we mentioned. Plus mental assessment for the patient. So antiemetics, H2 blockers or proton pump inhibitor, offer dietary advice, oral hydration, assessing the mental health. After that, we will reassess after 24 hours and after 72 hours. If the condition is improving, we will continue in the same care. But if the condition there is no improving, we can add second or third antiemetic. Also, we can titrate to a high dose or replace one of two medication with other medication, or we will shift the patient directly to inpatient if there is any red flags. So if the patient it's not improving or there is a red flag here, directly you will go for inpatient management, not ambulatory daycare management. Ambulatory daycare management, if there is a PQE scoring more than or equal to 13, or the patient have unable to tolerate from the start any oral antibiotic, or community measures have been failed, but there is no any red flags. Having red flags equal go for inpatient. So this is the management for the patient in community. Management for patient in ambulatory daycare is here, either more than or equal to 13, or inability to tolerate the oral medication, or community measures have been failed. After sending the patient to ambulatory unit, firstly, we will prescribe antiemetic as intramuscular or IV. We will prescribe IV fluid, and please concentrate 0.9% saline and 20 millimole of potassium chloride over 1 to 2 hours. These are the regimen for the fluid replacement, because this is a single best answer question. It was there in one of the old books for SPA. Thiamine replaced, as I mentioned, either thiamine 3 times per day or Paprinix, which is the complex one. After that, we will reassess the patient again. If the patient develop GERD, for all the patient, we will consider, as we mentioned here, either in the community or in the ambulatory daycare. We will give H2 blocker or proton pump inhibitor again if there is GERD or gastritis, thiamine supplementation, and laxative if required, constipation, and VTE risk assessment. This will be done for all the patient with nausea and vomiting in pregnancy. Then we will reassess the patient after giving her, inserting the cannula and taking a blood test and giving antiemetics and the fluids, saline with potassium chloride, and the thiamine supplements. Will reassess the patient. If the condition improved, okay. If the condition is not improved or there is red flags, we will shift to inpatient care. The third chart is about inpatient management. In inpatient management, we will also prescribe antiemetics in intramuscular or IM. We will give also 0.9% saline with potassium chloride. With monitoring the electrolyte, we will give also the thiamine, but here we will prescribe venous thromboprophylaxis, and we will prescribe H2 blockers and proton pump inhibitor for patient with GERD or gastritis, and we will schedule ultrasound scan to confirm the viability. We can consider enteral or parenteral nutrition in case of all the other medical therapy have been failed. So the extra thing here in the inpatient, we will continue in the IV fluids. We will monitor the electrolyte daily, and we will give venous thromboprophylaxis, and we will do ultrasound to confirm the viability and to assess the trophoblastic disease and multiple pregnancies. And we can consider enteral or parenteral nutrition as a last option if all these things are not helpful. On discharge, we should up titrating the antiemetics, encourage the oral fluids, offer dietary advice, and provide contact number for early pregnancy unit. And please concentrate. This box is very important because it's written clearly in the new guideline that giving advice for the women with hyperemesis gravidarum in the current attack in patient, give her advice about the discharge and how to eat and drink and medication will take, will reduce the risk of readmission again. So it's important to talk with the patient about the discharge. Patient in postpartum care and planning for future pregnancy who have severe hyperemesis gravidarum are at risk of post-traumatic stress disease, and in the future pregnancy there is an early use of lifestyle modification should be used. We will talk about this. And preemptive use of doxylamine and pyridoxine can be used to reduce the severity of the disease in subsequent pregnancy. If this patient having previous hyperemesis in the previous pregnancy requiring admission, so we need from the start to talk about the management of the hyperemesis, and we will talk about this in the next slides. When discharged, the patient woman should only be discharged once appropriate antiemetic therapy have been tolerated, adequate oral nutrition and hydration have been tolerated, management of any concurrent condition is completed. This means that we will not refer the patient to community until she are being able to eat and drink and to take oral antiemetics and treating any concurrent medication, any concurrent problem either related to the hyperemesis or comorbidities not related to the hyperemesis like epilepsy or HIV or all the other comorbidities. At the time of discharge, it's essential that women are advised to continue with their antiemetics where appropriate, and they know how to access the future care. Women with severe nausea and vomiting and hyperemesis who have been continued symptoms in the late second or third trimester, she should offer serial scans to monitor fetal growth. And here I have one question, so please concentrate. As per this guideline, they tell that we will do serial scan to monitor the fetal growth if the patient continue to have nausea and vomiting and hyperemesis in the late second or third trimester. Is there any other thing that will let us to have also serial growth scan in this patient? Please answer the question in the chat bar. Is there any other indication to do serial growth scan for patient with nausea and vomiting and hyperemesis? Hello. Anyone have answer? Monica said anorexia. Any answer? Just answer in the chat bar, please. GDM, BIH, it's not relating to the condition. I mean, anything related to the hyperemesis, preeclampsia. All these are not related to the hyperemesis. I mean, anything related, not a comorbidities or an antenatal care. No, not multifetal or trophoblastic. We for sure. Yes, Dr. Nesreen El Sharif. If the patient is using steroid and continue on steroid, for sure we need to do serial growth scan to assess the fetal growth. So in the nausea and vomiting and hyperemesis gravidarum, we will do serial growth scan either if we have symptoms still in the late second or in the third trimester, or if the patient is still using steroid, either injections or prednisone tablet. We need to assess the fetal growth by serial growth scan. So patient using steroids in hyperemesis gravidarum required to do firstly monitor the blood pressure, screening for gestational diabetes, and serial scan for assessing the fetal growth. Please remember this. Failure to ensure this will increase the risk of chance of readmission. As I told you, failure to talk with the patient about the discharge point, it will increase the risk of readmission again to the hospital. Continued treatment may reduce the need of hospital readmission, and women with low pregnancy weight are at increased risk of preterm and low birth weight. So women with low pregnancy weight gain and having nausea and vomiting and hyperemesis having a risk of having preterm or low birth weight again. Almost 1/3 of the women will be readmitted with the same pregnancy also. So readmission in the same pregnancy is 1/3 of the cases. And it's a single best answer question as well. So please, in order to know or to calculate all the percentages in the guideline, 1/3 of the cases will be readmitted. So how many cases will having liver function problem with the hyperemesis gravidarum? Anyone answer? Anyone attend from the start of the session? Yes. Thank you, Dr. Hadir. Thank you, Dr. Monica. Thank you, Dr. Tariq. Thank you, Dr. Rasha. 40%. And how percentage of the women that will have thyroid function problem or thyroid function derangement? 2/3. Yes. Thank you so much. So one thing also, the level of ketones should not be used to inform clinical decision making about treatment or hydration status. So forget anything as per the guideline around the ketonuria. The ketonuria will not diagnose, will not being a diagnostic criteria, will not add anything in the management, and will not make us to do any informed clinical decision about the treatment or hydration status. Fluid management in this patient, normal saline, 0.5 potassium chloride, with additional to the potassium chloride in each pack, and administration guided by daily monitoring of electrolyte. So it's very important when you have a single best answer and he told you how you will do a fluid replacement, and they just give you two answers. One of them are normal saline with potassium chloride, and the second option is normal potassium with normal saline with additional potassium chloride with monitoring daily the electrolyte. You should use this option because it's a very important point as per the new guideline to do daily monitoring of the electrolytes. Use of dextrose infusion for fluid replacement in nausea and vomiting and hyperemesis, it's not recommended. It's recommended only to prevent and treat starvation ketosis. If the patient has starvation ketosis, you can add dextrose infusion, but you should add thiamine either alone or with Paprinix, which is the vitamin B complex. Mental issues with nausea and vomiting and hyperemesis, practitioners should carry out full assessment of the physical, mental status during the pregnancy, and you should refer the patient early for psychological support if necessary. Pre-existing mental health condition may be exacerbated by the hyperemesis gravidarum. Prescribing oral medications are not being taken or kept down because of the vomiting, and therefore consideration to alternative route of administration and proactive use of antiemetic and appropriate referral should be considered. So please, this is one of the comorbidities of the patient to having a mental health issue. So if there is a problem about oral medications, you should seek help from the start and treating the condition and administer alternative route of administration of the medication that will treat the condition by the help of perinatal mental health specialist. Depressive symptoms and poor mental health are associated with severity of nausea and vomiting. This means the severe form may aggravate the depression and poor mental health state. Women with hyperemesis gravidarum are 3 to 6 times more likely than women with nausea and vomiting with pregnancy, having low quality of life. And constant nausea is the symptoms that most adversely affect the quality of life. So again and percentage. Nausea and vomiting, hyperemesis gravidarum are 3 to 6 times more than the nausea and vomiting with pregnancy, have risk of affection the quality of life. It's a single best answer. Women who experience hyperemesis gravidarum in the pregnancy are at increased risk of perinatal mental health and anxiety and post-traumatic stress disorder in postpartum period, as we mentioned in the chart. This is also a single best answer. You should know about the mental health issues that may happen with the hyperemesis gravidarum, post-traumatic stress disorder, anxiety, postnatal depression. Lines of the management. The last line of the management, as we mentioned, after failing all the options, we will talk about the enteral tubal feeding or parenteral tubal feeding should be considered, but we need to refer the patient to gastroenterologist and MDT caring. Total parenteral nutrition is a high-risk intervention, and it may be useful in refractory cases only. So, to conclude all the line of the management, firstly, we will start with the antihistaminics, the Zomvia. If it's not helpful, we can add one thing. If it's not helpful, we can shift to the second line of the management. Second line of the management, 5 days of the medication of extrapyramidal manifestation, metoclopramide, or using ondansetron, or we can do mix between first and second line. If it's not helpful, okay, we will shift the patient to inpatient care to go for IVF fluid with antiemetics. If it's not helpful, we will go for the corticosteroid, 100 milligram hydrocortisone, then shift to the prednisolone after clinical improvement, then gradually tapering until the lowest effective dose. Then after that, we can shift the patient again to the first or second line of the management after clinically improvement. If all these measures are failed, we will talk about the enteral tubal feeding and parenteral tubal feeding, which is a high-risk intervention. It's done for only refractory cases, and we need to refer the patient to gastroenterologist and multidisciplinary team. Treatment option of antiemetics, corticosteroid, enteral tubal feeding, parenteral tubal feeding, and correction of the electrolyte or metabolic disturbances should be considered before decision of termination of pregnancy. So the last line, after failing all these points and the patient have something that's critical for her life, so we can decide about termination of pregnancy. Decision of termination of pregnancy need to be done by multidisciplinary team with documentation of therapeutic failure before termination. It's a very important point, and it's a single best answer point, because some women are going for termination of pregnancy before using all the lines of the treatment. So before termination, MDT plus documentation of therapeutic failure of all line of the management. Hyperemesis gravidarum are associated with high risk of termination of pregnancy, and there is around 10% of women with hyperemesis gravidarum undergo termination of pregnancy due to severity of symptoms. So it's a single best answer question. Termination of pregnancy in the hyperemesis gravidarum, it's around 10% of women due to severity of the symptoms. One important point also for the exam, which is the recurrence rate. Recurrence rate in this case, it's variable from 15 to 81% as per the recent guideline. The second thing, which is mild to moderate nausea and vomiting with pregnancy, does not appear to have any negative long-term effect on the developing fetus or the protective effect, and also may have a protective effect on the pregnancy. So there is no any effect on the fetus and the development of the fetus inside the body of the mother if she's still fetus. But on the later life, they found that there is a risk, increasing the risk of certain adverse health outcome in the infant born to women who suffer from hyperemesis gravidarum, including an anxiety disorder, testicular cancer, attention deficit hyperactivity disorder, and autism. It's a single best answer also question that hyperemesis gravidarum and nausea and vomiting with pregnancy will not affect on the fetus inside his mother, but it affect later in life at age up to 40 years with having risk including anxiety disorder, testicular cancer, attention deficit hyperactive disorder, and autism. Reducing risk in the next pregnancy by early lifestyle. Please concentrate here because this is also new point as per the recent guideline. Early use of lifestyle and dietary modification and antiemetic that were useful in the index pregnancy is advised to reduce the risk in nausea and vomiting and hyperemesis in the current pregnancy. I mean that if I use Zonvia in the previous pregnancy and it was very helpful and helped me and the vomiting is stopped, so in the next pregnancy directly I will use the same medication to reduce the nausea and vomiting and hyperemesis in the current second pregnancy. There is a low recurrence risk with preemptive antiemetic before symptoms begin. I mean that in the next pregnancy, I will start the same antiemetic that was effective with me in the previous pregnancy, but I will start it before the symptoms. I mean, if the symptom in the previous pregnancy start while I was 10 weeks, so please start the same antiemetic in the next pregnancy at 9 or 8 weeks in order to save this patient from the hyperemesis gravidarum. Women who have experienced hyperemesis gravidarum in 2 or more pregnancies reported that early use of antiemetic was a factor in reducing number of hospital admission that they had in the second pregnancy. So that's why I'm telling about this. It's a critical new point and may came in the single best answer, because if you use the same effective antiemetic that you use in the previous pregnancy and you use it before the symptom begin, so you will protect yourself from admission in the hospital in the second pregnancy. And this was the last point in the hyperemesis gravidarum. Anyone have any question in the hyperemesis gravidarum?